As I said, it is a multi-disciplinary collaboration. We are delighted where we are able to do sonography at the Buffalo Neuroimaging Analysis Center. Karen Marr is here, and she really has headed this effort. The clinical examination is headed by Bianca at the MS Center at Jacobs Neurologic Institute. All the imaging analysis is done at BNAC. The MR acquisition is done at Kaleida Hospital at the Buffalo General Hospital. The CT studies and as well as the interventions are performed by UB Neurosurgery at the Gate Circle Hospital. So really, it is a full circle of expertise. The study population is primarily patients who have a diagnosis of relapsing remitting MS. Their disability scale was limited to up to 5.5 with the EDSS score. And we wanted to make sure that patients were not going to come in and enroll in this trial as an alternative to conventional accepted therapies, because this is experimental therapy. And therefore, we made sure that all patients that we enrolled were currently on accepted medical therapies. We wanted to make sure that we followed the current availability of criteria, and the one we have are the ones originally proposed by Zamboni. None of us believed that they would be the ones that would stick for 10 years down the road, but certainly those were the ones that we started off with to make sure that we had the criteria by Doppler. We did not want to treat somebody who was on active steroid therapy because they just were recovering from an actual event. Tysabri is a new drug, has shown some real promise, and we did not want to confound our results by including that. Similarly, a few other exclusion criteria. Obviously, if you did not want to undergo endovascular therapy, we would not enroll you. The idea here was that before you conduct a randomized trial, you need to know what the procedure is. And I personally had never performed a venous angioplasty for multiple sclerosis. I had performed venous angioplasty for narrowing of veins inside the brain for other medical conditions, narrowing of the sinuses causing increased brain pressure, blindness, pseudotumor, etc., etc. But I never performed it for MS. So before we embarked on a randomized trial, we approached the IRB for approval to perform 10 open label cases. What does open label mean? Means that we will treat all 10 of them. But this will be in the phase where we are trying to figure out what constitutes the actual procedure. How much angioplasty do you need to perform? How open do you need to have these vessels? How long do you keep the balloon open? How do you thin the blood? How do you manage blood thinners afterwards? Do you do any blood thinners afterwards, et cetera, et cetera? And so this was an incredibly informative phase, and we are happy to report that we were able to complete the first 10 patients. These first 10 patient results were presented in Bologna earlier this summer, where we were happy to report that there was no major adverse event. So this procedure was performed incredibly safely. There was one minor adverse event where a patient felt that they had increased numbness in their legs, which resulted in an overnight additional hospital stay, which resolved by the next day. There was no other adverse event at all. And so we believe that our study was safe enough, and based on those grounds, the IRB gave us permission to proceed with the randomized part. These patients would be followed at 30 days, 3 months, and at 6 months to really assess the safety element. Because if you're going to look at efficacy, you can't really look at efficacy if everybody's being treated because you have nothing to compare it to. If you want to look at the effectiveness of therapy, you need to have a control group that was not treated. And phase 2 patients would be followed in exactly the same fashion. We are happy to report we are 50% through the study as far as the enrollment is concerned. We have another 10 patients that have to be randomized as yet. These patients are being kept completely blinded as to what the treatment is being offered, and the studies continues to do extremely well. The study objectives are really to assess the safety. We did that, but we'll continue to do that for the next 20 patients as well. But then also to try to look at CCSVI criteria as documented by Doppler and by TCD. So the TCD is the Doppler when you do it in the head. You look at veins and blood flow of blood vessels in the brain, and the Doppler is of the neck, and you look at both these and to see if you can have better criteria. Second, the tool that has been incredibly useful, and I have to comment that this was just fantastic that we were able to utilize this technology that had previously never been utilized for really looking at venous disease. We had routinely used it for arterial disease, such as in the heart, when you're doing angioplasty for narrowing in the heart blood vessels, or in the carotid artery. We had found it to be extremely useful. But what we found was that when you use this technology, you're performing an ultrasound from the inside of a vein, rather than the Doppler, which is being performed from the surface of the skin. And this allowed us to visualize abnormalities that we had not contemplated existed. And that has been one of the most powerful tools in our armamentarium in understanding the venous anomalies. And we continue to compile this and in a prospective fashion compare this with CT, with MR, and with a whole variety of other tools to really get a comprehensive picture of the abnormalities. The next thing is, I told you about the effectiveness of the therapy. You want to look at the disease effect. So we want to look at how disabled these patients are. So we want to look at the EDSS score. But not only that, we want to make sure that if there is some benefit, which you all and we have read on the same sources you have, whether it's the internet or personal communication, what is that effect? Is this an effect that can be measured in terms of a fatigue score, so there's less fatigue? Well, let's measure fatigue score. Is it a difference in the degree of attention that can be maintained? Well, let's look at functional MRI. Is it a matter of quality of life? Well, let's look at measures of quality of life. If this is cognitive assessment, let's do cognitive assessments. If this is a matter of changes in sort of thickness in the eye retina where it affects vision, well, let's look at that. So we have tried to make this cohort as intensively studied as possible, and I don't believe there are too many other studies that have really looked at patients as intensively as we are to really try to see if there is a benefit. Let's try to pick it up, and then we can go from there. If there's no benefit, this may be a limited study, but at least will give us a good basis to conduct larger studies and know what we need to look for an effect. This is really the tail end where we are using a whole variety of procedures. The selective venography, we're using intravascular ultrasound, which really shows us small septi as described earlier by Dr. Zivadinov, the Doppler, MRV, and CT venography, which allows us to see this azygous vein, which cannot be seen by any other modality, at least at this point. It can be seen by MRI, can be seen by Doppler, but CTV allows us to see it. So these are all analyses which we continue to do, and we'll certainly see how patients do. As I told you, it's been very, very safe, and the secondary treatment outcomes I also managed. Again, I will not sort of prolong your, I think I can strain to see the small print. It certainly looks much smaller now than it did last night. Yeah. So I want to sort of, one more thing I want to tell you is, how do you blind? Okay? So blinding is extremely important. Blinding is important because if the patient has an idea as to what was done, they can conjure up effects which may actually be detectable and measurable in many of those measures that we are studying. That's the placebo effect. Placebo effect is very, very real. The power of the human imagination and psyche is much greater than what we give it credit for. And so we, in our first 10 patients, tried a whole bunch of different strategies to blind the patient. And I'm not going to disclose all the strategies we use because they can potentially be used for patients to figure out what was done. But I can tell you we have gone to great lengths to make sure our patients are blinded. And to date, what we do is we actually test for how effective our blindness assay is. Next morning, we ask the patient, what do you think we did? And how sure are you? And at this point, the no clue category is 100%, and I'm certainly happy with that. I think I'm going to skip these, and Robert, if you want to come back up at this point. Thank you.
Thank you, Adnan. Great presentation.